Welcome to Mastering and Guideline in Ultrasound and Echo.
Hi everyone. Here is answer of the case study 14. Actually, this case is one of the best case that show how much echocardiography has good and significant role in cardiovascular disease. And at the end of this answer, I mentioned those people had right answer, and please, those people email me to my Gmail and get your access to the master group for 1 month. Here was the 63 years old man with the chest pain, a typic of the coronary artery syndrome presentation with EKG, giant T invert. When we say giant T invert means the T invert more than 10 millimeter. And in precordial lead with troponin a little high, and so they did CAT. In CAT, the probability of Takotsubo syndrome suggested, and then on the transthoracic echo with definity contrast, we found those clips that you saw in the case study, and we will go evaluate and see what is the correct answer. Some of you mentioned some correct answer in some aspect, but not correct completely. Let's go one by one. Even though negative giant T wave or inverted T wave, especially we can see in precordial lead, is a hallmark of the apical hypertrophy cardiomyopathy, but is not specific for that one. It can be seen in other situations, including non-ischemic. In this case, for example, you can see patient with Takotsubo, apical Takotsubo, had giant negative T inverted in the precordial lead too, or you can see in the right ventricular hypertrophy or electrolyte abnormality, and so on. So the giant negative T wave is not diagnostic. In apical hypertrophy in 2D, most of the time we can see a characteristic feature of the thickening of the apex myocardium, but most diagnostic technique is in the ventriculography that we can see A shape at the diastole at the heart, and is a feature, diagnostic feature of the apical hypertrophy. But most of the time we don't need the ventriculography with the 2D with or without contrast. We can appreciate and measure thickness of the apex, and it's very easy to diagnose. In this case, we don't see any feature of the hypertrophy. As you can see here, apex myocardium at the apex is not only thickening, is thinning too, and here you can read disrupted here at this level. So we don't have hypertrophy of the myocardium. In apical obstructive hypertrophic, as you can see in this case here, 2D with the color, you can see this part get the impression of the aneurysmal or akinetic, and color you can see a turbulence at this level. And if you look at the contrast study in the same view, you can see a hypertrophic band at the level of the between mid and apical level. That is very obvious and clear, this hypertrophic area or band at that level, and can cause this high pressure at this level, and so you can see aneurysmal shape of the apex. But this characteristic is very easy. You can appreciate in the definity and here in the color Doppler, and if you put here continuous, you can see a classic pattern of dagger shape continuous wave on this level that this patient didn't have none of them, and you don't see any hypertrophic band that cause obstruction at this level. This patient didn't have. So apical obstructive hypertrophy and aneurysmal due to that one has been ruled out by this simple finding. Takotsubo can be diagnosed 100% only with the CAT and angiography. The angiography in this patient was normal, and based on the seeing pattern of the ballooning and other finding, EKG finding and blood test, troponin, the doctor suggests is a type of the Takotsubo syndrome or ballooning cardiomyopathy or whatever we call broken heart syndrome, so on. But the problem with the ventriculogram is that in ventriculogram we cannot see the territory and the shape and size of the myocardium and continuity of the myocardium. That is the problem. Ventriculogram only detect the territory of the endocardial inside of the left ventricle cavity. You cannot appreciate the structure of the myocardium. And if you look at the case, you can see the contrast has been filled this area. If during systole, you can see this part looks like bulging. And you can see based on this pattern, the doctor in ventriculogram, it give this impression because the contrast and dye in the ventriculogram go all the way up to here. So it gives impression in ventriculogram as a ballooning of the apex. And shortly I'm going to explain this and the contrast 2D on the transthoracic. As you can see, the myocardium at close to the apex, suddenly they are separate and rupture. It's very simple and easy. You can see and contrast go beyond the myocardium that will be here. This is your myocardium, and so it goes here, not only this area, a little higher too. And we can appreciate here, most probably there is some blood clot forming and fibrin start forming at this level. So we have territory of the this area up to here, give impression of the aneurysmal shape. But the most important characteristic feature is this rupture of the myocardium at this level. Why is sometimes disappear? Because during contraction, the plane of sector change, and it looks the impression is contraction very strong and goes and disappear. That is the reason. Here you can see exactly at this specific view, it looks like aneurysm. That is the reason I try to show if is that aneurysm is really aneurysm, this part, or no, is rupture. So in this apical 4, I tried, I couldn't show completely is that aneurysm or rupture. I tried this view, apical 2, a little here, separate and disconnected at this level, and we have contrast material here there. You have to explain why beyond the myocardium we have contrast. That is the point. Why beyond the myocardium this one? So if you put all together plus this contrast go beyond the myocardium and a little here some echogenicity and unecho layer that can be fresh blood clot at this level, and the other view that I'm showing here, you can see completely myocardium rupture at this level. Is a classic pseudoaneurysm, but unusual in apex. Usually apical rupture doesn't give pseudoaneurysm. Most of the pseudoaneurysm of the left ventricle is at the level of basal, especially basal inferior infarction. at the apex is unusual. Patient stay alive and get this restricted rupture or pseudoaneurysm of the apex. These two people, especially Black Wolf with explanation. Good job, Miss or Mr. Black Wolf. You did great and good explanation. And Dr. Chaudhary, they answered correctly. Please email to my Gmail and send your full name. I make some way you have access to the master group for 1 month. I hope everyone liked this lecture. Up to the next time. Have a wonderful time.